It is my pleasure to welcome you to the 9th Annual Ann Dial McMillan Endowed Lecture in Family and Child Health. It is hard to believe, Ann, that it's the 9th. It really is. This lecture has seen amazing growth over the years. Its visibility has increased since its inception, and we owe that to Ann, who allowed us to name this lecture in her honor, and it reflects her lifelong interest in family and child issues. So, Ann, thank you very much. For many years, Ann McMillan has been an advocate for our community through her dedication to a wide variety of activities. She is always generous with her time, donations of time and energy and thoughtfulness about some of our community's most complex problems related to children and families, and has been active on numerous community and civic boards, including Children's of Alabama, the Birmingham Area Chamber, and of the American Red Cross, both of which she served as board chair, and the Women's Fund. As Vice President for Community Affairs at South Trust Wachovia, she managed charitable contributions until her retirement, and now she continues that tradition with leadership positions in such community organizations as Leadership Birmingham, Leadership Alabama, as well as the UAB Leadership Cabinet. But it goes without saying that her most exciting volunteer role, is serving as a member of the Broad Street Committee, which is the advisory committee for the School of Public Health, and we thank you for that. Ann has received many awards over the years, among others, Junior League of Birmingham, Metropolitan YMCA, and Girl Scouts of Cahaba Council. Ann is here today with her husband, George. George, thank you for being here, former Lieutenant Governor of the state of Alabama.
Sara Rosenbaum, J.D., is the Harold and Jane Hirsch Professor of Health Law and Policy and founding chair of the Department of Health Policy at the Milken Institute School of Public Health at George Washington University. A graduate of Wesleyan University and Boston University Law School, Professor Rosenbaum has devoted her career to issues of health justice for populations who are medically underserved as a result of race, poverty, disability, or cultural exclusion. And some students had the opportunity to talk with her this morning about some of her stories, and it was fascinating. It was wonderful. An honored teacher and scholar, a highly popular speaker, and a widely read writer on many aspects of health law and policy, Professor Rosenbaum has emphasized public engagement as a core element of her professional life, providing public service to 6 presidential administrations and 19 Congresses. She is best known for her work on the expansion of Medicaid, expanding healthcare access to medically underserved communities, civil rights and healthcare, and national health reform. Professor Rosenbaum is the lead author of Law and the American Healthcare System, published by Foundations Press in 2012, which provides an in-depth exploration of the interaction between law and the U.S. healthcare system. She has received many national awards for her work and is a past chair of Academy Health. A member of the National Academies of Science, Engineering, and Medicine, Professor Rosenbaum serves on the CDC Directors Advisory Committee and has served on CDC's Advisory Committee on Immunization Practice. She's a founding commissioner and chair of the Medicaid and CHIP Payment and Access Commission, which advises Congress on federal Medicaid policy. We are thrilled to have you, so welcome.
It's wonderful to be here. I've actually had occasion over the course of my career to spend some time in Alabama. I made my first trip here over 35 years ago and was in both Montgomery and Birmingham, and barely recognized Birmingham, I have to say. I'm not sure that I would ever have realized that it was the same Birmingham I came to, and of course, your School of Public Health is very special. We were talking a little bit before about schools of public health in the South and what a unique mission schools of public health, nursing, medicine, carry, the historic work that they have done along with your hospitals and your clinics because of the history of segregation and exclusion in healthcare and the role of so many health professionals in really, changing how things are here. In addition to having established the Department of Health Policy at GW, I was very fortunate to be able to establish at GW 2 additional programs, one being an endowed law program, and my chair is named after the endowers, Harold and Jane Hirsch, And the other is a program known as the Geiger-Gibson Program in Community Health Policy. And Jack Geiger and Count Gibson, of course, are fabled people. Count has been dead now for about a decade, but their work as part of the Medical Committee for Human Rights, and they worked alongside Dr. King, was quite extraordinary. And in fact, Jack, Dr. Geiger, who's still alive in failing health now, but still as sharp as he was when I first met him 40 years ago, was on the Edmund Pettus Bridge, and he is the person who was able to get Congressman Lewis moved off the bridge and to safety and health care when he was so badly injured. And so for all kinds of reasons, Alabama plays a very historic role in health care and civil rights. It was really the place where what has emerged as the community health centers movement was first dreamt up by Jack and Count, and the contributions of so many people from this state and other states has really been, historic, and did much to shape my own thinking when I first went into law. It was having been fortunate enough to meet people like Jack and Count, and to be able to shape a legal career that tried to capture some of what they did as physicians. That certainly was a guiding light for me. So I'm going to spend some time talking with you about child health policy. I'm going to show you some slides. I'm an awful slide. Actually, I didn't make any of these slides. I sat with my research assistant and said, gee, could we make a picture of X or Y, or can we find a picture of Z? But lawyers, I don't know how you were as a lawyer in terms of using PowerPoint slides. No, this is not what lawyers do. We use words, not slides. But I am going to show a few slides. But I want to try and move us to sort of a broader discussion about the issues that you now are beginning to grapple with here in the state. You've been grappling with them for a long time, but it is a sort of particular chapter in grappling that you have now embarked on, because I think it's so emblematic of the efforts going on around the country and the importance of those efforts to child health policy nationally, and the degree to which what happens here in Alabama is, extremely important for the health of children in the state. And you have many counterparts who are engaged in the same struggles. In fact, I sent an email to Vicki Wakino. Vicki is the wonderful person who heads the Centers for Medicaid and Children's Services. She heads the program in Washington for President Obama, and we go way back in time together. And I said to her, I'm getting a lot of requests related to child health and the kind of system transformation work that's underway now. And she quickly wanted to know, where, and I said, well, Alabama's happening, Iowa, Florida, named off a couple of other states. So things that are unfolding here are unfolding in many places, and they hold great promise, but also great challenges. So I figured that Alabama was as good a ground zero as any place might be in the country to talk about these issues. So I want to start with this picture, and I put this up not because I'm using it not to illustrate the Affordable Care Act. There's actually much more recent illustrations of the Affordable Care Act's effects on coverage. In fact, you notice that it ends in 2012, so it's 2 full years before we began to see the effects of the Affordable Care Act. I'm putting this picture up so that you can see what has been happening and what has been happening for, in fact, 35 years now in the United States. And it's been happening quite steadily for children, quite dramatically for children, less or so for adults, although the picture since 2014 is probably going to become more dramatic for adults, not so much in Alabama for reasons we'll talk about, I'm sure. But what you can see, if you look, if you look at the red line, you can see that beginning in 1980, the pattern of private insurance coverage for children in the U.S., and of course, when we talk about private insurance, we mean employment-based coverage. Before the Affordable Care Act, there was virtually no individual market. It was basically non-existent. We don't need to worry about it, at least not for right now. But it was never a great system for children to begin with. Fewer than 80%, less than 80% of children in the United States in 1980, so before the tremendous economic unraveling that we've been living through now for people, especially for people with high school education or less who are engaged in manufacturing work. So this unraveling had not really set in as harshly as it has set in. But it was already, it was poised to start. But when you talk with economists, labor economists, they say the mid-'70s were sort of the apex of good-paying jobs with good benefits, and then things began to go south. And so we only had coverage for about 80% of children through the employment-based system in 1980. It was good, but it was not great. When I started doing my work on Medicaid in the mid-'70s, I can remember Medicaid for children, we used to go, door to door, visiting offices and congressional offices, explaining and showing pictures that were a lot cruder then, because we didn't have all of these ways of making such great pictures. But we would whip out tables showing that children were not part of employment-based coverage, that there were a lot of children in working families who had no hook into coverage. But what has happened since 1980, and I show this picture in great part because the acceleration began well before the Medicaid expansion that sort of took hold in the late 1980s for real, and then achieved full expansion by the mid-2000s. So this began before that, and there are a lot of people who've written about the phenomenon known as health insurance crowd out, it's not where I want to spend my time. There's a lot of controversy around the issue of health insurance crowd out. Do public benefits crowd out private insurance? And I always am amused by this literature, because in fact the unraveling started in earnest when there was nothing to crowd out. The unraveling was already underway when the discussions about Medicaid reform began to reach full fruition. So you can see that by 2012, we are well under 60% of children having employment-based coverage, and the number probably today is in the low 50%. And if you think about your own experience with employment-based coverage, many of you, most of us in this room, depend on employment-based health insurance, or somebody in our family does. You can, your own experience tells you why this is happening. Some of it's happening because of shifts, labor shifts that have resulted in more jobs that don't carry benefits, and some of this is happening because of different family formation patterns, so a lot more children concentrated in single-parent families, where basically the odds of having a parent with employment-based coverage go down. But a lot of it's also happening because of the cost of family coverage. Right now at George Washington University, we're the biggest private employer in Washington, so we're emblematic of the strongest employers. And what it costs for the university to cover a family, and what it costs the family to contribute to family coverage, is just enormous. And we've, of course, started to do what a number of employers now do, which is income adjust our premium contributions. But the income adjustment basically peters out way soon. And we have lots of families who are making, not that much above median wages in Washington, where life is very expensive, who can't afford family coverage. So you see children steadily falling out of family coverage. And what you see in the purple line on the bottom is this trajectory of children moving into public coverage. And again, this is before the Affordable Care Act. The marketplaces have been, as it turns out, not so important for children for reasons we can talk about. They should be much more important than they are, actually. But what we're seeing in the purple line is Medicaid and CHIP working in tandem to pull children back into coverage with spectacular results in terms of the proportion of children with insurance today. If you look at the adult line, you see sort of the same story, but the unraveling and the shifting are just not happening quite so fast. That is, adults with private insurance coverage are on the downslope, but we didn't have anything prior to 2014 to take its place. There was no equivalent to Medicaid and CHIP for adults. So there was a downslope, but not much of an upslope. And again, same story, the downslope began for adults. It already was underway by the early 1980s when we went through the Great Recession of late 79 into 82. But it was really the tremendous economic crisis of the mid-2000s that pushed the line down. And if you look at insurance data today, it's leveled off some, but you do not see this great recovery of employment-based benefits that might have come with economic recovery, because the economic recovery has not produced jobs in those sectors typically, particularly, again, for people with limited education that carry benefits. Alabama is a very interesting state. I mean, it had been a long time since I looked at Alabama statistics. And, of course, I think lots about Alabama in the context of the current debate over Medicaid expansion, because Alabama remains one of now it's only about 17 states where South Dakota is coming into Medicaid this summer. So I think it's 17 states that are still out. Unfortunately, of course, it is a swath. I mean, it is this geographically crystallized swath of states that have not opted to expand Medicaid for adults. And I will tell you, although this is a talk on child health policy, I'm sure I don't have to tell you in this room, we were talking before about sort of the public health sensibility of life, that a child health policy means that everybody in the family has insurance. If you're casting about from a healthcare vantage point for a child health policy, you do not leave older siblings without coverage. You do not leave people like me. I'm 64 years old. I'm not a grandmother yet. I wish I were. But you do not leave somebody like me, a grandmother, without coverage. You do not leave without coverage people who are absolutely integral to the well-being of children. Particularly when they're low income, because of the burden of illness that lower income adults bear. But I say that and I park it over to one side because it's sort of such an obvious fact right now about Alabama. We can come back to it, but I'm not sure how far beyond that threshold discussion we could get, because the fact of coverage or lack thereof simply stops. It's a showstopper for everything else that you would want to do in health system reform. But children in Alabama are very interesting, and I really had no idea until I started to prepare for this talk just what you have achieved down here. And I look around the room and I know why. I mean, the historic commitment of public health here, people like McMillan, the dedication to making the world work better for children is extraordinarily strong here. And so if you look at your combined Medicaid and CHIP eligibility standards, which of course, the two programs work in tandem, you have some Medicaid expansion, and then you have CHIP on top of that, but your combined program puts you in the absolute top tier of states. I mean, really only New York which, as New York always does. New York basically, went berserk on public insurance for children especially. They cover everybody. And they got their hands slapped. Very interestingly, 50 years ago, New York got its hands slapped when it initially established Medicaid and established eligibility standards that were essentially covering the population. So New York has a track record, but you are, really in the top tier of states. You are far stronger than my own home state of Virginia, which on a per capita income basis is a much wealthier state. There's sort of no excuse for Virginia at all. And I spent a lot of time over the past 2 years counseling families who were caught in the Medicaid coverage gap, because of course Virginia doesn't have Medicaid either, not expanded Medicaid. And along the way, I also had to counsel families about other shortcomings of the new exchanges for children, and am very well acquainted with the fact that we stopped covering families at twice the federal poverty level, and we have thousands of children in Virginia caught in a coverage gap that you don't have here. So you have taken really a notable step that most states have not taken, and it's a great achievement. The other thing that I was quite struck by that sets you apart from a lot of the southern states is, and these are numbers, these are sort of not great numbers. So these are numbers on, and actually is with an offer rate for low wage employees. And for lower wage employees, the Alabama offer rate is quite close to the national offer rate. So you actually have a more vibrant employment-based health insurance system than many other southern states, and I know that's because your economic base is different here. This is a picture of children's health coverage again in Alabama. Excuse the fact that the D in Medicaid managed to make it below Medicaid, and it's actually Medicaid CHIP. But you can see, of course, this unbelievable picture here, and it looks like the rest of the country, where there's literally, it's a 50-50 split at this point down here. Nationally, it's a little bit less than that, but here, essentially, public insurance is covering 1 and 2 children. You have an uninsured number that's smaller than the national average, which is just an extraordinary accomplishment. And Medicaid, CHIP, and employer coverage are essentially tied as the primary sources of coverage. And again, this is just low-income children, and here, of course, the picture becomes much more startling. And you can see that for low-income children, meaning children below twice the federal poverty level, there is employer coverage, but it's 1 in 5 children. And that's true nationally. Again, you look quite standard nationally. If we were in Texas, the numbers wouldn't look anything like this. If we were in Florida, the numbers wouldn't look like this. So this is really a testament to what Alabama has decided to do with public insurance when it comes to children, and they've done it through Medicaid and CHIP. You, of course, know this already. You're financing 1 and 2 births through the Medicaid program. A little higher than the national average, which again is to be expected. Your per capita income is lower. But again, your entire obstetrical system in Alabama, it's not just the obstetrical system for poor women. We're all in the same obstetrical system. If you're having a baby in Alabama, I'm sure everybody goes to one of the same 10 or 15 hospitals around the state. And if you have a high-risk baby, or if you are a high-risk pregnant woman, there's probably 1 in 4, 1 in 5 places you may go in the state. Everybody's in the same boat. Everybody depends on the same core cluster of providers, particularly for the most vulnerable women and children. And so your entire obstetrical system is resting on the back of the Medicaid program. Medicaid, and of course the history of Medicaid and obstetrics is that Medicaid is credited as the single biggest financial factor in the reduction of infant mortality in the U.S., not because of having produced such healthy pregnancies, unfortunately, but because the financing that Medicaid pumped into the hospital system allowed the growth of newborn intensive care. And for that reason, we all have Medicaid to thank for the existence of the most advanced forms of health care for children at this point. Low-income adults, of course, are a different story. Your uninsured numbers for low-income adults are actually only slightly higher than the national average, because your employer coverage for low-income adults is somewhat high, a little bit higher than the national average. I can't tell you if it's statistically significant, but you do have a more vibrant employer market for low-income adults. Where you clearly are lagging is the coverage through Medicaid, where you are, about 10 percentage points off where we are going in the U.S. average, because you don't offer coverage for adults unless they happen to be pregnant or exceptionally poor parents, or adults with disabilities, or of course adults with disabilities who get Medicare. So you have very, very limited options for somebody. I hate it when people call them childless adults. If I lived down here and I were poor, I would need Medicaid, and I'm not a childless adult. I'm an adult with a grown child. And I think, it's very easy, and I'm sure a lot of attention has been paid to this, to overlook the demographics of who needs this coverage, and what they do, and who they are, and what their family characteristics are. But this is where you see the gap created by Alabama's policies. I want to turn just for a minute before I move to the system reform issues that are underway here. I want to just look at some state rankings, and here we pulled from the Commonwealth Fund. The Commonwealth Fund does very interesting state rankings work around health indicators, and so I brought the tables into my research assistant, and I said, could we make a picture out of this? And she came back with this and said, here's a picture. I said, that's very good. So you can see what the rankings look like from the Commonwealth Fund's statistical tables. When it comes to children without health insurance, you guys are tops. You have whittled the number down to a very low point, much lower than other states. You rank 6th in the U.S., and it's a testament not only to what you've done on paper to expand, but to the amount of effort that's obviously been put into enrollment, because you can't just expand a program. You got to work at getting people enrolled into it. But as we sort of start looking at your health rankings, you can see the issues which you are all, as public health people and health professionals, very familiar with. So, when it comes to children who are overweight or obese, you are 42nd in the U.S. This is 2015 data, so pretty current. You can see mortality amenable to health care. This is all ages. Very serious problem here, meaning a lot of preventable death and disability. Infant mortality, your overall rank numbers still are high. They are high in the U.S. And years of potential life lost before age 75, which is, of course, again, you're public health people, so I don't need to tell you, this is one of the great bellwether measures of the health of a population. You rank also near the bottom. So the health care side of things, is one measure, and of course there you've taken the absolutely essential first step of insuring people. I mean, you can't get to the downstream problems and the upstream problems if people don't have any health insurance. You just can't manage their care. You can't get them into care, you can't keep them in care, and it's not just me saying this, it's a lot of studies showing the relationship between insurance coverage and care. You can have limited programs, which are wonderful. They do wonderful work, whether it's a public health clinic that does prenatal care and STD screenings, or whether it's a community health center that takes care of people regardless of the source of their insurance coverage. These are wonderful things, but if you ask any clinician or any health worker in any one of those settings, you will hear immediately that the situation is almost impossible when the person doesn't have health insurance coverage. So on that front, where children are concerned, Alabama is strikingly strong. But the coverage is not translating. It's not translating into care for preventable conditions. It's not working in tandem with other upstream interventions that are not health care, but that deal with health. And that's what shows up in these measures. So now I want to turn to sort of what's happening here. So after I accepted the speaking engagement, which was, of course, a number of months ago, along comes all of the attention being paid to Alabama as one of the great demonstration states. Alabama, as I'm sure everybody in the room knows, and you're obviously, I can't even begin to be current the way you all are in terms of the daily to and fro's of this. So I'm talking to you now from a national perspective. Alabama sought and received, after a long negotiation period, these things are always very long negotiations, permission under special federal demonstration authority known as Section 1115. It's part of the Social Security Act, and it was added to the Social Security Act 55 years ago now. It predates Medicaid by years. It was added to give the federal government the flexibility that it needs to work with states to test out new ways of doing things under social welfare programs that are state administered, like Medicaid, like welfare. So Alabama was given permission under Section 1115 to introduce certain changes that have been, for a long time, a feature of health system reform in many states, but is sort of a later development here in Alabama. We know it, it has many names. We know it as managed care. We know it as now accountable care. We know it is apparently down here as regional care. In some states, it's known as collective care. I mean, it has just name after name after name. But it rests on a few distinct principles, which are at least potentially going to start unfolding here and unfold. They're already unfolding, but the pace is probably going to pick up because the federal grant award that the state got sets a very rapid timetable for this transformation. And in fact, that's not unusual. The federal government, when it's given permission to other states, has done the same thing. The states are on a forced march to move very fast. And I think part of that forced march is so that they can pull the health delivery system along with them. You say, look, we're on a very rapid timetable, so everybody's got to sort of pull together on this. And that's what's potentially going to happen here. And the systems that are going to emerge from this, but theoretically, at least on the other end, are going to have certain features. And the features vary from state to state. And when I went to the university, I ended up concentrating all of my research effort around this phenomenon as it happened in states. And I did that because my practice had me dealing with this as it was happening in states going back to the mid-'70s. So the features of these systems are, of course, a fair amount of vertical integration. It may not be ownership. I mean, it may be that a big hospital system owns clinics, owns pharmacies, owns labs, and, group health which began its life in Seattle, almost a century ago, is an example of a completely owned system where the doctors are on staff, the hospital is built and owned by the corporation, everything is owned. But more typically, this vertical integration is achieved through contractual arrangements and affiliation agreements. It's not an ownership, and it may not even be an exclusive contractual arrangement. You may have clinics that are under contract with, well, 2 or 3 different systems. I mean, in the private insurance world, our group practice at the university is under contract probably to 50 different insurers. I mean, they contract with everybody. But typically, they're contractual arrangements, and there are reasons why in Medicaid, the process is tends to be a lot more exclusive and integrated because there are just fewer providers who see patients. And so you don't have 40 plans to choose from. You have a few, if you have a choice at all. But there are these vertically integrated systems that have sort of sewn themselves together. They form a delivery network. People enroll in them. There's a formal enrollment process. And they are contracted to deliver a defined set of benefits. So it has the feel. I mean, it's like, if you think, all I'm describing is your own insurance coverage at this point. But a more structured version of this is what's happening in Medicaid. They are under contract to a sponsor, which in this case would be the Medicaid agency, to deliver very specified benefits to their enrolled population. And they have to do so within a global budget. Now, the global budget may have some escape hatches. There are various ways in which a group sponsor and a delivery system might share risk. They may leave certain services out of the contractual arrangement because they are too costly and too hard to manage, and you have that going on here. They're too complex. Nobody really quite knows how to integrate them yet. And they have to operate under a global budget, and increasingly now, this is one of the great advances of the past 20 years, they are held to certain basic performance standards. And sometimes the performance standards feel like the right performance standards, and sometimes you look at the performance standards and say, I don't get it. Most of the stuff that is really a concern is not captured in a performance metric. So how are we going to know what's happening? And that's the system. And I've just described to you everybody's insurance card, probably, in this room. Give or take, a few bells and whistles. Those of us with private insurance typically can choose between a very tightly controlled network, which sometimes is referred to as an HMO, it depends on the state you're in, or we can opt for something that's more loosely configured called a preferred provider organization, a PPO, which ostensibly lets you go out of network, but of course today with the degradation of insurance, you're crazy to go out of network because the cost-sharing exposure is it's already bad enough in network, much less going out of network. So we are all in the same boat, but Medicaid is sort of the most advanced version of this because for all practical purposes, unless a service is carved out of that contract, the people who are enrolled in this system must get their care through their network or they are not insured. It's that simple. And the network is either going to figure out how to deliver the service to the patients, or the patients are not going to get treated. And the network and the corporation also have to figure out how to negotiate a budget they can live with. They have to figure out how to manage risk. They have to figure out how to exchange health information in an effective and timely fashion. Managing the finances of an integrated delivery system is incredibly difficult. And what essentially the 1115 demonstration waiver does for you all, assuming that the state ultimately goes forward. And I gather there's, some question about whether everybody is, now that you've gotten your approval, whether it's actually going to happen. But assuming it happens, the interesting thing about Alabama is that, I'm trying to remember the number now, I actually looked it up, something like 75% of the people in this demonstration are children. So, what we are talking about here is the reimagining of the pediatric healthcare system for the state. And because Medicaid is such a big player in pediatrics, taking away for a minute the CHIP children who are left in their own delivery systems, whatever their insurer sets up, although there's a lot of overlap, obviously. But you have so many children in Medicaid, and Medicaid is so important to pediatrics and obstetrics that whether this system, whether this transformation makes it or doesn't make it, will affect pediatrics generally in the state. That's the point. I mean, the point is that this happens to be a Medicaid demonstration, but in Alabama, I don't need to remind you now, the role of Medicaid in the lives of children here is quite overwhelming. So, I'm now going to share with you, for the final part of my talk, what I have learned both through my own research and from my work on Medicaid managed care. I'm going to lay out a number of things that if I were you, I would be paying lots of attention to. And I preface it by saying that I am actually a great believer in what is happening right now. I don't mean right now here in Alabama, although what I mean is that this notion of the integration of care and the development of global budgets, I think is an advance that if we can only figure out as a country how to do it right, brings us to places that have figured out how to insure their populations and insure them with good care using private healthcare providers, and don't have the uninsured numbers we do and don't have the health gaps we do. So I'm going to state my prejudice right out in front, that getting to a point where we can think globally about healthcare delivery and how to integrate healthcare delivery into the delivery of social welfare services generally, that's a good thing for the country. And so I applaud the state, actually, for taking this step. But it is very hard to take this step for one slice of the population and to go through the blizzard of changes that are needed without figuring out, everybody else who's doing this. Israel did it, Germany runs like this, Switzerland runs like this, global budgets, negotiated rates, private delivery systems. You're doing it on a population-wide basis. Here, we keep doing it for swaths of people, and it makes life very difficult for providers, especially, to have to sort of deal with 30 different payers coming at you, all of whom want to do things differently. That's part of the dilemma. So here are the things I would be paying attention to, if you're not already, and I'm sure you probably are. The first one is the actual transition. Okay, you are going to have a moment in time, if you think of it as a curtain going up on a play, when suddenly enrollment starts. And everybody's going to have, according to your demonstration specifications, your special terms and conditions as they're known, STCs. So like STC 13 on the list, there are like 90 different STCs. STC 13 says basically you're going to start enrolling everybody on a date certain, and people are going to have 30 days to choose. And if they don't choose, they will be default enrolled into a delivery system. And in some places, there might be a couple to choose from. There aren't that many RCOs around the state, as you know. In other places, there may not be more than one RCO, in which case people have to be given certain options. They have to be given an option to maybe stay out. But clearly, the terms of this, I think, must have been negotiated with an eye toward having enough RCOs so that the vast bulk of people, at least in urbanized areas, are going to be able to get locked into a delivery system. And when this happens, to the extent that your population has not already gone through this, they will have no idea what's going on. None. And it really will not matter how much the state has tried to pave the way through written materials, ads, paying providers and community organizations to sort of help with the process. And those are all really good and important things, and they should happen. And enrollment materials, I'm sure those of you in the room who do health education work, I mean, I'm not the one to tell you what enrollment materials would have to be like to be able to convey the right things to people. But no matter what happens, there will come a moment in time when people have a card, and it's going to take a community a while. They will, of course, the way we all have become used to networks, the Medicaid community will become used to networks, but it's going to take a while. And therefore, the most important thing anybody can do is try and figure out with families who are the most common sources of health care for the family. I mean, that's really what it boils down to. So if you're at a community health center where you're the family practice, both for the children and the adults, that's one strategy in terms of the outreach work that's done. If you are furnishing care through one of the UAB facilities that maybe has a pediatrics clinic, but not necessarily an adult clinic, I don't know enough about the UAB system to know, what the age range is served. You may be the choice of care for the parents, but not necessarily for the children. Again, I'm not telling you anything you don't know. Parents will always choose the place where their children's provider is. Always, always, always. And so if you have to make choices, choose where the child's regular source of care is. That's not necessarily the wisest thing to do, particularly for parents with serious health conditions and their children don't have such serious conditions, but you may get better loyalty and more in-network utilization. That's my own experience with working with families. They really think first and foremost about, where their children go for care and which program's going to serve their children. But it's going to happen in a very tightly compressed time frame. It's like being in a blizzard. You go into it, and then you're out of it in the back end, and suddenly everybody's enrolled. And then, of course, the issue is post-enrollment, is helping people. It's not just getting them hooked into a plan. It's making sure that once they're in the plan, a lot of time is spent with families on how to use their plan. Which means that the plans should be putting money into various kinds of health education activities, whether it's formal sessions, whether it's, at emergency departments where people show up, sitting and making part of the visit, learning how to use the plan in the simplest of terms. It's not a one-shot deal, and of course, Medicaid for adults is very fleeting. So you're going to have a lot of entry and exit from these networks as people fall in and fall out. My own bias is try and get people into a plan that has clinics that see patients when they're indigent and uninsured. Because you don't have Medicaid here. You don't have coverage of poor adults. Your coverage for children is good, and my guess is that your Medicaid children have a regular source of care that's every bit as strong, actually, in percentages as your privately insured children. But for adults, you'd be doing everybody a favor by trying to help them pick a plan that will also deal with them when they don't have coverage. Because they're going to have their coverage maybe for 4 months at a time, 5 months at a time. I don't know what the average length of enrollment for adults is here, but your eligibility levels, unless the adult has total disability or is pregnant, if you're a parent, the chances that your income is 23% of the poverty level, forever are low. I mean, you have little fluctuations, or you have other issues that throw you off the program. So that's a big issue, picking a plan with a network that'll work for that family. The second set of issues really has to do with coverage. So the contracts that these big systems are going to enter into are unbelievably complicated things, because Medicaid is an unbelievably complicated program. And if I leave you with nothing else, it is the recognition that not a single thing about the advent of managed care changes the state's coverage obligations to children. So in other words, Medicaid for children covers a huge array of services, preventive services, acute services, long-term services, and supports in many, many different settings. Nothing about what the state is doing changes the terms of coverage. The terms of coverage are the terms of coverage, and looking at the special terms and conditions, the federal government waived not an iota of coverage. Now, that doesn't mean that the managed care plan is, in fact, primarily responsible for that coverage. On the surface of things, a lot of services are what we call carved out. School clinic services are carved out. Certain MCH clinic services are carved out. Services for children with special needs, certain kinds of clinical providers and service systems are carved out. I will tell you that the gap, certain mental health services may be carved out. The gap between what they say on paper when they say something's carved out and how it works in practice, unbelievable. The amount of friction that develops when the prime contractor says, oh, well, for that you need to go to school health. We don't do that. We don't see children with these particular diagnoses. That's a school health service. You cannot believe, maybe that's true, maybe it's not true. If you're dealing with adults who have serious mental illness, there may be certain things that are contractual and certain things that are carved out. The act of figuring out these pressure points where the carved out service and the contractual service meet up is huge. It's the great flashpoint of managed care. In private insurance, we don't have this, because if it's not in your insurance plan, nobody else is covering it for you. But in Medicaid, you have to think of it as a Venn diagram. The contract sits inside the state plan. And the state puts certain things in the contract, and for a lot of good reasons leaves a lot of things out of the contract. But the state's going to struggle with this, the plans are going to struggle with this, the carved out providers are going to struggle with this. It's going to be an unending series of struggles, and what's going to happen slowly over time is that people are going to develop protocols for figuring out what's the process for quickly figuring out who's primarily responsible for a service, okay? Another issue that's buried in there for children is medical necessity. So again, Medicaid has a very special definition of medical necessity for children. It's unlike any other definition of medical necessity under any insurance plan anywhere in the United States. It's the EPSDT definition, and it's driven by the word early, right? Early and periodic screening, diagnosis, and treatment. Early does not modify only screening. It's early screening, early diagnosis, early treatment, which means that as soon as a child's health condition could be ameliorated by an intervention, the state is supposed to finance the intervention. And so it's not just, that service you get in the school, it's how quickly anybody's got to start treating a condition. You can't wait with a child until a condition becomes severe. You can't wait until the child is 3 standard deviations on a mental health measure before you start treating. The treating has to start early. And this is an issue in Medicaid, and nothing about managed care changes that. So how the state articulates medical necessity in its contracts, what the state says specifically about EPSDT in the contracts with these RCOs is, you are now at the 10th circle of hell in drafting a contract, and it's where your scrutiny as people who are concerned about children needs to be. Another big issue is going to be performance measurement, obviously the measures that are used, and actually HHS in the demonstration approval has identified a number of measures that it wants to use as measures that guide performance by the state, not by the contractors, although it's clearly by the contractors. But these are measures that will guide performance by the state in terms of, are you eligible for another year of payment? A lot of those measures are child health measures, which is great. But you know how performance measurement is. There may be lots of things that you think should be measured that have to do with certain kinds of serious and chronic health conditions or certain kinds of preventive services for children, particularly for adolescents who are sexually active, that are missing from these measures and metrics. And so the question is, what do you do about missing metrics? The relationship with excluded services is this question of sort of this point at which the contracted services and the remaining state plan services come together. This issue of transition between sources of coverage and care, a huge issue, meaning what happens as you fall in and out of coverage, and where do people who sometimes qualify for Medicaid and membership in an RCO, where do they get care when they're not in the system? Last two things I want to leave you with, it's not in the terms and conditions, and I wouldn't expect it to be, but I think it's something that you all should make a major focus of your work. The RCOs, I assume, will be led by a combination of public and private nonprofit hospitals. They are the hubs for the development of these new services. And these hospitals, as nonprofit entities, have community benefit obligations, which they, in a state like Alabama, I'm sure fulfill heavily in terms of financial assistance to needy people. But there's a whole other side of community benefit activities related to community health improvement and upstream investments, which tend to be less financially demanding than financial assistance would be, but they are very important. And one of the great advances of this model of care is that it forces the healthcare system to think much more globally about the health of its patients. And so for those of you who are active in community health needs assessment activities, who sit on advisory boards to large hospital systems that have community benefit spending obligations, that are also at the center of this activity, this RCO activity, there's a nexus there that you shouldn't miss. And there are certain places in the country where this nexus is really beginning to play itself out. Minnesota is a leader in this regard. Washington State, its Medicaid program, has been a leader in sort of trying to think about the link between delivery and upstream investments, and the provider systems are leading. Wisconsin has done a lot of work in this area. It is something that's gaining steam, that as part of the effort to think globally, budget-wise, think globally, health-wise, you can't help but run into housing and nutrition and education and all of the things that go to the social conditions of health. And the more you can pull community benefit activities together with what's happening on the healthcare side, the more ultimately the state may stand to succeed in its long-term cost containment aims.